This is going to be a session on introducing meta-analysis. It's meant to be, I will keep it as a non-technical, not too many technicalities, more a broad introduction to the concept of meta-analysis. So obviously you should be familiar with the broad steps of a Cochrane review. You've gone through the process of defining a review question, and you've planned your methods, you've written your protocol, you've already done your search and so on. And you've got to the point that you've collected your data, and now you need to analyze it and summarize it in some convenient way. And of course, in particularly medicine and in Cochrane reviews, that is normally through the process of statistical analysis and meta-analysis, which is what we'll consider today. So I'm going to take you through three sort of broad steps today. I'm going to look at what meta-analysis is, what its purpose is, and then we're going to look at how it's done, so the steps of meta-analysis, how it's conducted, and finish off with looking at how you actually present it to other people. Obviously, this is all sort of introductory ideas, so look at the Cochrane Handbook. Meta-analysis is covered in Chapter 10 of the Cochrane Handbook for the full sort of formal details of meta-analysis and its principles. So we'll imagine we're conducting a systematic review. We've identified some studies. So we've got 4 studies in this review, study A, B, C, and D. And we would like to summarize a particular outcome that they have reported. So they may perhaps report the risk of death for some disease on some intervention. So we'll have some outcome data for each study, for example, the number of events, the number of deaths in each study, as you can see there. And that will be summarized within the study as in some effect measure. So, for example, as a relative risk or an odds ratio, or for something more continuous data, it might be a mean difference. Hopefully you've seen the sessions on estimation of events that we've also done in Cochrane. So each study will have some effect estimate that is associated with it from its outcome data. And what we want to do, of course, is move to the review level and put them all together and summarize those data as a single effect measure across the whole systematic review. And that is meta-analysis. So fundamentally, meta-analysis is not a particularly complicated idea. It's really just trying to combine results from 2 or more studies in some average. And it really is essentially just an average in the way you probably all learned at school, you know, the classic take the value for each thing, add them up, and divide by how many there were kind of average that you probably learned at school. Although it's a very common part of systematic reviews, not all systematic reviews will have meta-analysis in them. The little diagram in there indicates obviously that many systematic reviews don't have meta-analyses in them, and there are meta-analyses done outside of systematic reviewing as well. So it's a statistical technique. It doesn't have to be done in systematic review, although it's most commonly done so within a systematic review. So why do we do it at all? What's the point of trying to do this averaging or summarizing across a systematic review? Why don't we just use the numbers that are in the review in each study? So obviously, an important initial step is just to look at the results of the studies. So we're quantifying the treatment effects, quantifying the effects in each study with a measurement of its uncertainty, its confidence interval, so that we can actually look at the results from each study and compare them head to head and look at them in a clean and clear way. So a first step, an important part of meta-analysis, is just simply looking at the evidence we have, the data we have from each study, and being able to do that clearly and simply. Obviously, if we perform meta-analysis, it's a bit jargony here, but to increase the power, that means to, obviously, if there is a benefit of a treatment with more studies, with a meta-analysis, we're more likely to be able to confirm that that treatment works than we could do in a single study. It increases the precision, so we're more certain about what the actual truth is. We're more clear about exactly how well an intervention does or does not work. We can start to look at the differences between studies. So, for example, we might be able to spot that some studies have a larger effect than others. Or we may be able to start to think about why that is. Is it something to do with the dose of the drug, or the way it was administered, or the people it was given to? we can start to investigate that. That is covered in much more detail on training sessions on heterogeneity, which you can also attend as part of this series. In relation to that, we can start to look at controversies or conflicts between studies. We may find, it's quite common to see one study claims that a new drug works really well, and a rival study will come along and claim it doesn't work at all. And we can start to look at, if we look at the whole body of evidence across all the studies, we can start to unpick why that difference might have occurred, what the truth is. And we can go on to build new hypotheses about interventions, arguing who they should be given to, when they should be given, what dose, how should we administer the treatment, and to who, and so on. So meta-analysis helps us then step forward in our research and ask where we should be going next. Should we be doing more studies, and what kind of studies should we be doing, for example? So that's all the reasons why we do a meta-analysis. We can't always do one. One of the classic arguments against not doing meta-analysis is it used to be sort of described as mixing apples and oranges. You've got a load of apples and you've got a load of oranges as studies, and you just stick them all together. And people have criticized meta-analysis as just sort of trying to lump together all kinds of different stuff, different studies that may or may not go together properly, rather than sort of carefully critiquing each individual study. So sort of in response to that, if you're going to do a meta-analysis, you need to be clear that, the studies are addressing the same question. So they're in the same intervention, the same kind of population, and so on, and that you're looking at the same outcome, and it has to be fairly precisely the same outcome. For example, death at 1 year is not number of deaths after 1 year is not the same as number of deaths after 2 years, for example. So you have to be careful about exactly what the outcome is that you're including in your meta-analysis. And this is a subjective judgment. There is no right or wrong answer to this question. When I teach meta-analysis, I like to distinguish between people who are lumpers and people who are splitters. Lumpers are people who like to put lots of different studies together in a meta-analysis and then investigate why they might be different. I tend to consider myself as a bit of a lumper. I will put studies together and then I will start to ask, why are they different? What are the differences? Splitters like to have very carefully defined inclusion criteria for meta-analysis. So the study should be exactly the same. And if they're slightly different, you do different meta-analyses for different subsets, different groups. So that's sort of splitting the studies rather more precisely into different categories. So there's this balance in meta-analysis between putting everything together and accepting that there'll be some difference, or trying to be more strict about what you include. Obviously, if you put a load of broad mix of studies together, you might be answering a fairly broad question. A classic example in this is many years ago, there was a meta-analysis of all kinds of intervention, all kinds of psychotherapy intervention to treat mental health conditions. And the meta-analysis didn't really concern itself with what the mental health condition was or exactly what the type of therapy was. It just took everything together, and it was criticized for doing that. But the reason was, of course, to look at the broad question of whether psychotherapy is useful at all. Does psychotherapy even work? And you have to start with that big, broad question to get down into the deeper questions later on. So that's kind of why you might want to have a broad mix of studies. Sometimes it makes sense to put lots of things together to answer a big, broad question. The other nice pat example I give is, why should we mix apples and oranges? Well, if the intervention is fruit, perhaps I want to look at the impact of fruit on cancer prevention. If you eat plenty of fruit, does your risk of cancer go down? And in that case, I'm not really concerned whether the trial used apples to boost someone's fruit intake or used oranges to boost someone's fruit intake, if the question just concerned with fruit. So again, it depends on what your outcome is, what your study is, what your PCOS criteria were for your review, and so on. But in contrast, if your meta-analysis is too diverse, too broad, you may just have a wide mess of stuff and not really be able to see anything. So you have to have a careful balance about what you do and don't include. And I can't obviously, that's a big, difficult question to cover in just one session. Another reason, of course, is you have to think about the quality of the studies. low quality studies will give you a low quality result, and putting low quality studies together doesn't make anything any better. The classic idea of garbage in, garbage out. Similarly, you could have problems if the classic example is publication bias, where studies don't publish if they get an unfavorable or result that doesn't go the way the company or the authors liked. So you have a load of, so the studies that do get published are the ones that went in the favorable direction, showing the treatment worked, for example. So you have to be careful about reporting bias. Are people only reporting the outcomes or the studies if they went well or gave the result people wanted to see? And of course, if we then do a meta-analysis of the studies that went well, we get a result that's misleading. So there's a balance again. We have to think about the quality of the studies themselves. We can't just be sticking in very poor quality studies. And we have to think about the overall risk of biases from whether studies were reported at all. So when can we actually do a meta-analysis? So we have to have, at a very trivial level, we have to have at least 2 studies. We have to have more than one study. It's a common problem in Cochrane reviews for people to do meta-analyses with only one study, and that is not recommended in Cochrane. It shouldn't be being done, but it still is. So guard against that and avoid a meta-analysis or doing this whole process when you've only got one study. As I said, as I've already labored the point, we have to be careful about ensuring that the studies are similar enough that the result will be meaningful. They have to have a similar outcome, similar p-costs, and so on. The outcome has to be measured in similar ways. So as I said already, we have to be very careful. If we're looking at death as an outcome, we might not be able to combine death at 1 year with death after 2 years, for example, or we can't really combine systolic blood pressure with diastolic blood pressure. So you have to be careful about exactly how the outcome has been measured. Has it measured in the same way? Another problem is if we've got things like patient-measured outcomes on some scale, like a pain scale. Are people using the same pain scale? Are different pain scales comparable? And again, these are all questions we have to think about during the process of our systematic review as to whether we can do it. And finally, we have to have the data. One of the big problems in trying to do meta-analyses is just having the data in the first place. Did the paper, the publication, present the data we need to do the meta-analysis? Did it actually report the number of deaths in their study? For example, if they didn't, we can't put them in a meta-analysis of the number of deaths. So we have to have the data available to us from the study as well. And that's obviously frequently the biggest barrier to doing meta-analysis, is just having the data at all. So that indicates that's sort of an introduction to the principles of meta-analysis and why we do it and when we can do it. I'm now going to think about exactly how we do a meta-analysis and what it actually is. So getting slightly more into the detail of the topic. So when we do a meta-analysis, we first have to, we need to identify what we are actually meta-analyzing. So what are the comparisons? So for example, what is the intervention we're looking at? What is the comparator we're looking at? What are we comparing? Not all meta-analyses are comparative. Some meta-analyses are just of single arm studies. We might be looking at risk or frequency of events. But generally speaking, we're making a comparison, or we're looking at an intervention. So we first have to be sure what intervention, what circumstances we're looking at. We'll need to think about the outcome. Again, I've already sort of stressed this. We need to know exactly what outcome we want to look at and exactly what kind of statistics we're going to use. So we need to decide in advance, are we going to use, say, a relative risk to analyze this, an odds ratio, a mean difference, or something else to analyze this data. So then we pull the data from the studies. We go to the paper, the PDF, whatever, and we extract that data from the study in our data extraction process. That occurs in one of 2 possible ways. We might actually extract the raw data itself. So, for example, we might pull out the number of deaths in a study, the number of people in each arm, the number of deaths in the intervention group, the number of deaths in the control group, pull all of that data out. Or sometimes we might pull out, if we're looking at relative risk, we might extract the relative risk from the study instead. So if a study reported the relative risk of death, we might extract that from our study and use that in a meta-analysis. In practical reality, we would normally do both. If we're doing a data extraction process, we try and collect the raw data, the numbers of events, and the outcome that the study presented, the relative risk or the odds ratio, for example. Then we've got one. Then we're going to actually do our meta-analysis. We're going to combine those results that we've pulled out, the data that we pulled out from the studies, and calculate our overall estimate, our meta-analytic estimate across the studies. Then we're going to start to look at, we need to think about, well, what happens if the results look different to each other, exploring the heterogeneity, to use the technical term. Again, that's more covered in the training session on heterogeneity. I'm not going to be covering that in detail here today. And we've got to start thinking about interpreting the results in the basis, does this intervention work? How well does it work? Is it worth using in practice, for example? So I'm going to use an example to illustrate how we do meta-analysis in practice. This is a made-up hypothetical systematic review about using caffeine or coffee to help impact your daytime drowsiness. So if you feel like me, you get to sort of mid-afternoon and you're feeling a bit like you're running out of energy, do you go and get a cup of coffee to help you plow through until the end of the day? That kind of idea. So we're going to be, we'll have studies that are going to compare caffeinated coffee to decaffeinated coffee, perhaps in a blinded way, but we're not going to worry too much about the details of the trials today. So we're going to look at sort of, and our broad review idea is looking at this, does this caffeine, choice of coffee impacts daytime drowsiness? So we'll need to break down our review into those comparisons. So we'll have to pick out the caffeinated coffee versus decaf coffee in each study, remembering that studies may have other treatments, other interventions that we may or may not be interested in. So yeah, reviews might have multiple comparisons. We might also be comparing coffee to tea, for example, in this review, and we're going to keep it simple here, just a straightforward caffeinated versus decaf coffee. But again, you'll have to make your own judgment about what counts what counts as caffeinated coffee here, what counts as decaf coffee in each group. For example, perhaps some studies had different levels of caffeination in their coffee. Which one do we include in our meta-analysis as an example? So you have to think about what constitutes caffeinated or decaf coffee in this case. And again, that's a subjective judgment that you'll have to be thinking about at your protocol stage and your study selection stage. So hopefully at your protocol level, you've decided what outcomes you want to measure from your review. I'm going to assume we're going to take three. Imagine we've got three outcomes here, whether or not you're asleep, whether you fall asleep during the trial, and whether you're irritable in some sense during the course of the day, or whether you get a headache as a result of drinking the coffee. So we have to think about what outcomes we want to measure. So here are sort of three outcome measures that might relate to drowsiness and use of caffeine. And we have to think about the effect measure that's going to be analyzed, that we want to analyze. So sleep and headaches are both dichotomous yes-no type outcomes. So a relative risk, a risk and a relative risk might be the most sensible option here. Irritability is presumably measured on some kind of scale that is patient-reported. So a mean difference or a standardized mean difference is more likely to be sensible there. So again, at the protocol stage, we're deciding on our outcomes and deciding on what measure we want to use to analyze those outcomes. With a bit of caution that the effect measure may depend on what is available in the studies. For example, we might find that studies all report odds ratios instead, so we have to switch from relative risks to odds ratios as an example. Or we might find that multiple different irritability scores, pain scores, scales are used, so we need to use a standardized mean difference to account for different scales, or we might have wanted to just use a mean difference on a common scale. So we sometimes have to be a little bit flexible as to what we actually do in a meta-analysis, because we are dependent, generally speaking, on what the studies report in a meta-analysis or based on published data. But normally speaking, we need to define what we're going to do in advance. So again, what we need to do, as you sort of saw on my slide earlier with 4 imaginary studies, we need to collect a summary statistic or the data from each contributing study. How are we going to pull that together into our meta-analysis? Well, one sort of trivial idea is to just imagine that instead of lots and lots of studies, they all constitute one very big study. So we just add we just add up together the total number of headaches across all the studies and the total number of people across all the studies, and that gives us, the risk of headache generally on average. So we could treat it as a single big study, just adding up all the numbers. The problem is, of course, if our studies are randomized, then just adding up all the numbers across all the studies breaks the randomization, and it actually gives the wrong answer. I don't have time to demonstrate a few examples of that, but if you do just add up numbers in this way, you're not actually respecting the fact that these are different studies with their own randomization and their own inclusion criteria. So that's not an option. We could opt for a simple average. As I mentioned, that classic average we all learned at school, add up the numbers from each study, add up the relative risks from each study, divide by the number of studies there were. That's option. So essentially, we're treating all studies as completely equal and equivalent. But that's probably not realistic because some studies will be bigger and probably more accurate. Some studies will be smaller, maybe some studies more biased than others. So a simple average that just sort of adds up all the numbers and divides by the total is not going to make sense. So what about a weighted average? Oh, I'm jumping ahead myself there. So a weighted average, this is where we're going to go. We want to weight the studies in some way so that we are giving more weight or more importance, more stress to studies that are more meaningful, more important, larger in some way. So how do we go about doing that? Well, generally speaking, it sort of makes conceptual sense that, the more information, the more participants, the more events, generally the larger the study was, the more weight or the more influence it should have in our meta-analysis. We should be sort of thinking the bigger studies should be more influential in our meta-analysis in some way. So we want our larger studies to have more weight. So one statistical option is to think about weighting based on the study uncertainty or the study standard error, because that sort of tells us something about how informative a study is. Generally speaking, a large trial will have small standard error, although that's not always absolutely strictly the case. It's fairly commonly true that the bigger the study is, the smaller its standard error, the smaller its uncertainty. That's inconvenient because obviously we'd like the larger study to have the larger weight, so we can't just weight directly by standard error, because we want the smaller standard error studies to go to the larger weights. So what we do is use a simple trick of if a standard error is small, then 1 divided by that standard error will be large. So we just flip things over, we do 1 divided by the standard error, and we know now that way the larger studies will be more influential. So we're going to weight by this sort of inverse of the 1 over the information in the studies. And again, we're going to give more weight to more information. So we could use 1 over the standard error as the weight. We don't actually do that for mathematical reasons. We prefer to use 1 over the variance, i.e. 1 over the standard error squared as our weight. So that's the weight we're going to use. So for each study, we need an estimate of its effect, say its relative risk, and we need an estimate of its variance or its standard error squared to give us the weight for the meta-analysis. And then the average, the pooled estimate, is we just take the estimates, we multiply them by the weights, and we add all those up, and then we divide that by the total sum of all the weights. So it's like a classic, again, it's very much like a classic school maths lesson average. We're adding up all the studies and we're dividing by the number of studies, but in this case, we're adding the weight into our pool. So it's the estimate times the weight added up, divided by the sum of the weights. So you can sort of see there that if the study is larger, therefore has more weight, it's going to be more influential in that average, that pooled estimate at the bottom there. So now let's get into the nitty-gritty of this particular meta-analysis. Here are our 7 studies. You might notice the slightly punning names for these for these studies. We've got 7 studies in our meta-analysis. We're going to think about headache as our outcome. So this data table tells us the number of headaches and the total number of patients in the caffeinated group and in the decaffeinated group. So, for example, the Amore-Corthea trial had 2 headaches in the caffeine group among 31 participants and 10 headaches in the decaf group among 34 participants. So I'm not going to formally show how the weights are calculated here because that's a mathematical thing I don't have time for. But I am just going to show you what the weights would be in the meta-analysis. And you can see hopefully straight away that the biggest weight here, the 26.4%, goes to the Nor's Cafe study, the 5th one down, which we can see is indeed the largest study here. It's the only study with over 60 patients in both arms. So it's not surprising that should get the largest weight. In a meta-analysis of outcomes of yes/no outcomes like headache, dichotomous outcomes, the number of events is also important in the weight. So we can see, for example, that the Mama-Kappa study, the 3rd one down, gets 22% just over of the weight. And the Delicosa trial gets almost the same weight at 21% and just under 22%. So they have very similar weights. Although you can see that the Delicosa trial is slightly smaller, they have fairly similar numbers of events, 10 and 9 and 12 and 9. So they're similar in size, they have similar number of events, so they get about the same weight. At the opposite end, we can see the Morocana trial, which only had just over 30 patients and 4 events, gets very little weight. It only gets basically 3% of the weight. So there's the idea here that we're going to give the bigger studies with more events, more information in them, a larger weight overall. So what are our options if we go into RevMan, for example? For dichotomous outcomes like headache, like death, and for continuous outcomes like irritability, pain scores, and so on, then this inverse variance meta-analysis I've just described, the idea of calculating 1 over the variance and using that as a weight in a weighted average, is by far the most commonly used method around the world for meta-analysis. It's straightforward to use. It's the one that pretty much everybody uses. And it's available for essentially any kind of data. Although dichotomous, continuous, other forms of data also work very well with inverse variance approaches. If you have dichotomous yes/no type data like headache, then in RevMan, there's also a method called mental Hansel, which is currently the default in RevMan. It's common in Cochrane reviews. It's a useful method if you have very few events. So, for example, if some of our studies had no headaches in the decaf arm at all, for example, or only 1 or 2, then mental Hansel is quite a useful method. With some caution, I should point out that it really is only really intended for rare event meta-analysis with few events. It gets used as the default. We are arguing that it should not be, so I advise against using it as the default and just accepting it as the default in meta-analysis. It's for historical reasons, it's got lumped as the default in RevMan. I wouldn't recommend it as such. It's only really intended for rare event data. There's a third option in RevMan called the Peto method, which only works with odds ratios, which again is good with few events, though I have to admit, I would strongly advise never to use that unless you're very, very confident that it is the right method to use. It's a historical method that's largely no longer used, as more modern methods have superseded it. But again, so you have those 3 methods in RevMan. Personally speaking, slightly from the perspective of the statistical methods group at Cochrane, inverse variance should be your preference generally. except perhaps when you've got very, very few events and the Mantle Hansel makes more sense. I don't have time to go into the precise details of all the whys and wherefores of that, but just bear that in mind. So this is what you will obviously see if you go into RevMan. So you will be, you'll obviously have to name your outcome, in this case, headache. You'll have to input your data. You want to declare that this is a dichotomous outcome. It's because it's a yes/no type outcome. You'll name your intervention groups, caffeinated versus decaffeinated. And then at the bottom, you're going to do the stats bit. So you're going to suggest, we're going to select an inverse variance meta-analysis. We're going to do a meta-analysis of relative risks or risk ratios. I'm not going to go into details of fixed and random effects meta-analysis in this session, but we're going to focus on the fixed effect concept today. So all these things that you have to select. I should just warn you that obviously RevMan is constantly changing. Some of these things, some of the options are different now to what is in this slide, and there are different options in the boxes. This is a couple of years ago. But the basic principle remains. So essentially, we've essentially done our meta-analysis. Cochrane, the RevMan, does all the actual calculations for us. We just have to know the method that we want and the principles of what data we're putting into it. The more important thing in many ways is how we present the results and then interpret them afterwards. So the classic way to do that is with what's called a forest plot. And a forest plot is so called because it has lots and lots of lines in it that looks a little bit, if you squint and turn your head to one side, like a lot of trees. So it's it comes broadly from the idea of, trying to find the wood for the trees is the English idiom that sometimes gets used for meta-analysis. You're trying to find the precise thing among all the mess and the complexity. It's not named after a Dr. Forrest. If he's you sometimes still see that people giving forest plots with a capital F. It's not, it's just a forest in the sense of lots of trees. So a forest plot looks in RevMan at least a bit like this. Here is an overall forest plot for our meta-analysis of coffee using those 7 studies that I covered a second ago. So RevMan tells us at the top what groups we had, what arms we have, what we are comparing, caffeinated to decaffeinated coffee in this case. We've got our studies down the left-hand side. We've got our data from the studies that we extracted from our papers. It's worth mentioning at this point that normally in RevMan, we extract the data from the studies, like the number of headaches and the total number of patients. We don't extract or calculate the relative risks because RevMan will do that for us. So we generally just pick out the data, the raw data, the number of events, and we use that as the basis of what we're going to put in our data extraction that then goes into RevMan. So there's the data from the studies that was shown a few slides ago. RevMan tells us the summaries, so the total number of events, the total number of people is at the bottom there. Here are our weights, exactly the same weights as we calculated before because we got it from RevMan in the first place. As you can see, with the Norse Cafe, the largest study, getting more weights than any others, 26%, and the Morocona, the smallest study, getting the least weight at 3%. RevMan calculates the actual risk ratio, the relative risk for each study for you automatically. So the risk ratio is varying here from about 0.22 to 3.4, so quite a wide range there of relative risks. But the most important bit is the actual figure on the right. And one thing I have to admit I slightly dislike about Cochrane forest plots is that there's an awful lot of space given to the data and not enough space given to the actual plot. It's the image, the picture on the right, that's the important thing that we actually look at to think about our meta-analysis. And it does get a little bit lost in all the data, but focus on the picture bit, not on the numbers bit for this session. So what we've got here is a series of essentially horizontal lines, each line indicating a different study. The little blue square that sits at the point on the horizontal axis where the relative risk is. So you can see, for example, that the top Amora Coffea study had a relative risk of 0.22. So that sits at the 0.22 point position on the left-hand side of the plot. And we go up to, for example, Morocona, a risk ratio of 3.4. So that sits on the other side at 3.4, going down vertically. I should point out that the axis on the bottom is logarithmic. You can see that it goes from 0.01 to 0.1 to 1 to 10 to 100. That's a logarithmic scale, which we normally use for relative risks and odds ratios. So where the dot is, where the little blue square is, indicates the relative risk. The horizontal bar tells us the confidence interval for the study. So going back, for example, to Amora Coffea, that had a confidence interval here from 0.05 to 0.92. And that's what the width of that horizontal black line is. You can sort of see it goes up to about just under 1 and quite a long way down to 0.05. And again, for all of the other studies. And finally, the size of the blue blob, this blue square, indicates to us the weight of that study. So you can see that I'm just trying to find it, the Norse Cafe study has the biggest square, and just immediately above it, the Morocona study has the smallest square because it had the smallest weight. So the plot itself tells us essentially everything we need to know about the data, about the study. And it immediately allows us to start looking at those, comparing the studies. In a forest plot, we have a very convenient central vertical line, in this case at 1, which is the point at which we distinguish between things being to one side favouring caffeine and the other side favouring decaffeinated coffee. So we can immediately see, for example, that the Amora Coffea study is in the direction of favouring caffeine, whereas most of the other studies are in the direction of favouring decaf. So the Amora Coffea study is a bit of a different from the rest. It's in the opposite direction. So we can look at that. We've got our scale at the bottom. That tells us, we normally label it like this to indicate which side is the caffeine favouring side and which side is the decaf favouring side, so that we're clear on which side is more or less beneficial. And so we can start to see things like the differences between the studies. We can see that sort of, other than Amora Coffea, the studies are reasonably sort of consistent. They're all in a slightly favouring decaf direction, but not enormously so. It's only really Amora Coffea that's slightly different from the rest. And finally, we have our actual meta-analysis results. So we've done our average, we've done our weighted average based on the inverse variance. And in this case, the bold numbers at the bottom of the risk ratio column gives us the actual result. In this case, a risk ratio of 1.38, a confidence interval from 0.96 to 2. And that's indicated on the image by that sort of diamond shape. It looks a bit square on this version, but it's supposed to be a diamond. So where the vertical center of the diamond indicates the actual result of the meta-analysis, that relative risk of 1.38, and the width of the diamond gives the confidence interval. And you can just see that that diamond just tweaks and hits that vertical line at 1 because its relative risk does drop down to 0.96. So we can see, and again, we can interpret we've got here a result which is certainly in the direction of favouring decaf coffee, and that decaf coffee is generally better. You get fewer headaches with decaf coffee, but it's not quite statistically significant in the conventional sense. Its confidence interval does include 1, so we're not completely convinced that that decaf coffee is better, but in terms of headache prevention, but it's certainly looking in that direction. The main reason, of course, we're not completely convinced is that our Amora Coffea study is sitting there in the opposite direction, not helping us. So we always present results with a confidence interval, because that's giving us our sort of best guess of effect and telling us our overall uncertainty in the result. So obviously we have to be careful of interpreting confidence intervals. We're looking at, so the narrower confidence interval is, the more precisely we're sure about the effect estimate. So for example, as we say, if it was 0.7 to 0.8, we're pretty confident that it's in that very narrow range. And the wider it gets, of course, the less and less certain we are about the result. So we're always presenting our meta-analysis with our confidence interval. I haven't discussed how to calculate the confidence interval because it's more mathematically complicated, and RevMan does it for you anyway. But bear in mind, obviously, any meta-analysis we do has a confidence interval and an uncertainty, just like each study does. And the confidence interval itself is largely indicated by the sample size, how much data we have overall in the meta-analysis, the more studies we have, the bigger they are, the narrower the confidence interval generally will be. With some difference, because if results are conflicting or if results are different, that tends to make the confidence interval wider, because if the studies are different from each other, the confidence interval tends to inflate, as you will just see if you attend the heterogeneity session. And finally, so we have to be careful again about thinking about statistical significance. If, like in the example, the confidence interval includes the null value, the one, the relative risk of one in this case, be careful about interpreting that. It's very common for people to say wrongly that that means there's no effect or no evidence of effect. You can see that's not true from the data we had. There was clearly a direction in favor of decaf coffee. It just didn't quite reach significance. So maybe another study would have helped. We may have jumped over significance had we had another study. And so we have to think about, again, also we have to think about whether or not the result we've seen is clinically meaningful or useful. So to give an example of that is a much bigger meta-analysis. This is a meta-analysis of whether or not a reduced fat diet leads to weight loss. So the forest plot is showing the amount of weight loss in kilograms people get from either a reduced fat diet or a non-reduced fat or usual fat diet. So to summarize that, we can see our little diamond at the bottom. We've got lots and lots of studies, but our diamond at the bottom, which is a summary looking at its result. It's a mean difference in this case because it's a continuous measure of weight. A mean difference of 1.54 kilograms, confidence interval from minus 1.97 to minus 1.12. And so it's clearly significant. It's quite a narrow confidence interval, but is 1.54 kilos of reduction in weight actually clinically meaningful? It's not a very big reduction in weight. So it looks like a reduced fat diet does lower your weight, but not by very much. So whether it be clinically worthwhile massively changing your diet to try and lose just 1.5 kilos, that's the question, that's the uncertainty here. So you always have to balance statistics with clinical importance and clinical meaning. And that's, of course, important when interpreting meta-analyses. So just to sort of bring us to a summary, we need to be consistent in presenting your results. Forest plots in a Cochrane review will normally be linked as figures to the data, to the sections in your review. Generally speaking, the primary outcomes, the main outcomes of your review will be the ones that are highlighted in your Cochrane review, and other forest plots are generally will appear in the supplements later on if you start to do secondary outcomes or subgroups, secondary meta-analyses. Again, we said avoid forest plots with just a single study. Lots of people do it. Unfortunately, it shouldn't really be done. But it doesn't really help you or tell you anything because it's not a proper meta-analysis because you're not pooling data. There are other ways of looking at data instead. You can present data tables, summaries in text, for example. You may have non-standard or non-numerical data that you need to present as well. So all these things, it's not just forest plots. There are data tables and other things that have to be presented when you're thinking about your review and your meta-analysis. So what needs to go in the protocol? Well, you'll have to decide whether or not you want to do a meta-analysis and what model you want to do. So what method are you going to use? You need to say, are you going to use inverse variance, for example? What outcomes are you going to do? Is a meta-analysis sensible at all for this data? To sum up, meta-analysis is generally used. It's the most commonly used way to summarize data from systematic reviews. It's not always possible. It's not always appropriate, though. You have to think carefully about what the data that's going to go in it is, what are the outcomes, the comparisons, what methods you're going to use, and so it has to be thought through carefully. The forest plot is the way to display it and interpret it, but always be careful about interpreting your results, thinking about the science behind them, not just the stats. Think about what they really mean to reality and to the people reading will review aren't going to be statisticians or systematic reviewers who are interested in the medical interpretation of it. And I will finish with a few references, books to read, and I'll thank various people, including my fellow members of the Statistical Methods group, Julian Higgins, who came up with a lot of this text, and Sally Hopewell, and others.